Good, thank you. The next item on the agenda is the NHS performance report. What I would like to do with the approval of the board is invite Barbara to take item 6 and item 7 together, which would bring in also the update on preparedness for winter 2014-15. I think we're all agreed on that. Thank you. Barbara. I'm sorry, before Barbara goes right ahead. Straight to Barbara. Yeah. Okay.
Thank you, Chair, to take the two items together. Two papers, one which looks at the performance in the NHS. Most importantly, is the NHS delivering to patients the standards that we believe are right for them. And then the one which focuses on our preparation for winter. So what I'll do, I'll talk in terms of the standards and performance first on those things which aren't around urgent care, because clearly that's the element which is most aligned with our winter planning. I'll start with referral to treatment, if I may, which is the promise we've made to patients that the vast majority of them will have their treatment started within 18 weeks of being referred for care. As you will be aware, an extra 250 million was put into the system in order to treat more patients who had waited longer than we would have wanted them to have done so between July and November. So in actual fact, the standards haven't been met during that period for the simple reason there was an amnesty. We made a positive decision to treat more long waiters in that time and therefore not to aspire to meet the 9 out of 10. A lot of activity has been undertaken, but sadly I think that there were a significant number of trusts and foundation trusts who were just not able to deliver the additional activity to patients that they had hoped. That leaves us with some concerns about ensuring that we're back on track in terms of sustainability. So in order to make sure that that is the case, we're working with trusts at the moment, particularly the ones who were unable to put on the additional activity, for them to work with their local independent sector providers and work themselves to make sure that additional patients are treated. The whole of the 250 million is used up, and whatever is done is necessary to get us back on track so that we can ensure patients are treated in a timely way. The second area, I'll take cancer and diagnostics together if I can, because I think there's an intimate connection between the two. Clearly, waiting for a diagnosis is a real issue for patients, and it's much more of a worry if the diagnosis that you're waiting for is potentially around cancer. We have seen a dip in the standards for these two in recent months. Part of that's a good thing, because as you'll be aware, there have been some very significant public campaigns to raise the public's awareness of potential early symptoms of cancer. And because of that, we've seen a huge increase in the numbers of patients coming forward to their GPs and then being referred for diagnostic tests or then onto the cancer pathway. And I think that surge has meant that we haven't recently been meeting the very, very tough targets that have been set, the very tough standards. Nobody should underestimate across all standards how well the NHS delivers in terms of seeing people very quickly and delivering high quality services. But we are on track to put that back on time. Some of the RTT money will have had a very significant impact on that, because some of the RTT money will of course have paid for diagnostic tests such as endoscopies, where patients are admitted and and that's a very important test in terms of diagnosing cancer. So we do expect to see an improvement on that. The other three areas that are really important for patients, and we've reported on regularly, so we won't dwell on them this week unless anybody has any questions, are psychological therapies, access to those, dementia and the diagnosis for dementia, and the Transforming Care programme. In particular with the Transforming Care programme, this is about patients with learning disability. This is about making sure that those patients are treated in the right place, that those who don't need to be in residential accommodation aren't. I know that Jane's going to be bringing a report on that to the board next time, so we might leave that, but unless anyone has any questions on progress. In terms of psychological therapies and dementia, we have been hampered to some extent with these. We know we've set ourselves some very significant standards for the two, important standards, that patients who have mental health problems get access to these really beneficial psychological therapies, and that having got the access, that a goodly percentage of them get better. So we set high standards for that. We set high standards for the number of patients who are diagnosed with dementia, because again we know that for many patients not having the diagnosis means that the support around them can't be put in place. We now are starting to get regular and accurate information, which we've been working on. It is quite difficult in some of these to identify baselines and to be absolutely sure that we've got the right numbers on which to base our have we improved, because if your baselines are on, the percentage of improvement. But we're starting to see much more robust information about that. At the moment, for neither are we absolutely on track in terms of the trajectories that we set ourselves as where we would like to be. But for both of them, there's a huge amount of work going on across the system. Bruce and his teams working on that with central support to those patches that aren't doing as well as they otherwise might. My operational team having a particular focus. We are very clear about which areas aren't delivering the standards that we want to see, which ones are furthest away from target, and personal interventions from either myself or the regional directors or members of Bruce's senior team to those areas to make sure that we relentlessly pursue the standards that we've set for ourselves and can improve on those as we get to the year end. So if I could go on to the urgent care standards and the what we're doing about that, which would then take us into the second paper. The two areas, the standards that we measure here are the A&E standards, not only how long patients wait to be treated in A&E, and if I can make the point, because so often people say that the 4-hour standard is about waiting to be seen. It isn't. It's 4 hours to be treated and discharged home or admitted to a bed if that's what you need. And again, nobody should underestimate what an excellent standard of care that is for patients. So there's that standard alongside the standards about when patients need to be admitted, how long they might wait for a bed, sometimes described as trolley waits, and then the time taken for our ambulances to respond to urgent calls. For both of these two, we haven't been meeting the very high standards that we've set ourselves over the last few weeks. It has been an exceptionally busy time, and nobody disputes that there is a significant rise in the numbers of patients needing our emergency treatment and emergency care services. But I want to make very clear, and I think the second paper goes into this, is that the amount of planning that goes on in the NHS to deal with winter is and always has been very substantial. It's something that we are used to doing. It's something we do every year. We have ramped up our activity in terms of getting our plans in place this year. Fortunately, as Paul said, we had the extra 700 million that's gone into the system that came in earlier, which gave health economies the opportunity to put their plans in place. And it's a whole systems issue. This is not just about what happens in the A&E department. The A&E department is the barometer, and when things are getting really busy, we see patients many more patients in A&E are being admitted, and that's where we start to see the standards. That's where we measure the standard. But notwithstanding that, in order to provide really comprehensive and good urgent care services, we should not underestimate how much needs to be done out of hospital, whether that's in our NHS community services or GP services or in social care services, supporting people to be as well as they can be, and when they are ill, to be able to stay in their own homes or within their communities for their treatments. So the amount of planning that has gone on this year in order to make us resilient for the winter. We know that December is a difficult month, but we also know that January and February can be busier times. A huge amount of planning. And I think that what I would like to say is that the board can be assured that a safe urgent care service is in place and will continue to be in place throughout the winter. Our absolute priority is safety and the quality of care that patients receive. So one of the things we will explicitly be doing in terms of working with our services is ensuring that In those instances where patients do have to wait, we have set ourselves a very high standard that 95 out of 100 patients should be seen, treated, discharged or admitted within 4 hours, the highest of any industrialisation. At the moment, we're still providing that level of service for 91 out of 100 patients, but we're now also focusing on where patients need to wait to make sure that the quality of the clinical care when they are waiting, so if somebody has to wait for a bed, that there's full and absolute clinical supervision before they are admitted to exactly where they should be in the hospital. I would make the point that in all of this as well, I think that the public can help because there is a need for people to save our emergency services, particularly such as A&E and ambulance services, for those patients who really need them. Now, I recognise when patients are in doubt that they obviously will turn to what they see as the most appropriate care, but I do think it's really important to remember that we have a helpline, a 111 helpline that people can pick up and ring when they don't need a 999 emergency, and that 111 helpline will direct them to what might be the most appropriate care. In many instances, make them appointments, give them advice, and also that our primary care services across the country, albeit stretched, are there to signpost, help and advise people. So not only general practice, but the pharmacy has an enormous role to play because our pharmacies are there. They have experts who can deal with minor ailments and give people advice about whether some over-the-counter medicine would be sufficient and that they don't need to either go to the GP or go to A&E. So I think it is worth making that point. The final thing on the paper, and then I'll see if there's anyone has any questions, is just on Ebola. I promised the board that we'd bring a regular update. Fortunately, there still hasn't been a case of Ebola in the UK, apart from the one individual who was repatriated. But that doesn't mean that we aren't still making enormous efforts to make sure that we are prepared for all eventualities. Much of the work we're doing at the moment is around supporting West Africa, and the NHS response at a time when our NHS staff are working unbelievably hard to deliver these urgent care services. We have some fantastic people who have volunteered to go and help out in West Africa, and we're putting the NHS putting a lot of support around identifying and helping those people, helping Public Health England to make sure that the screening for Ebola is comprehensive and appropriate. There's lots of NHS input into that, but finally and most importantly making sure our staff are absolutely fully and properly trained, so that if they come across a suspected case of Ebola, then all frontline staff know what to do, and then particularly when the suspicion is higher or when a patient has been diagnosed with Ebola, that we've got absolutely the right care, particularly at the Royal Free, and then potentially in other backup hospitals should we have to deal with more than a couple of cases of Ebola. So that work continues, and again I feel this is all more about assurance for the board that the NHS is prepared for winter, tough though it is, and is prepared for any issues we have around Ebola.
Well, thank you, Barbara. Both of these papers ask the board to note, which is a sort of passive sense. Actually, the board does have to be, as you just said, assured as to the performance of the NHS and as to resilience for the coming winter period. So can I ask members of the board, please, for comments or questions to Barbara on these two papers? Margaret.
Yes, I've got a few questions, please, Barbara. The first one is on the winter resilience, and you've quite rightly said that we need to be assured that there are plans being built with regard to resilience, and we need to have visibility. Have you put a timeline on when you want to have sight in the year so that we can gain that assurance? That's the first point. The second point is in connection with the Transforming Care programme. There's been quite an emphasis, quite rightly, on getting people into appropriate locations, and I just wanted, I trust that the emphasis on appropriate locations is not just on on translocation, it's also on continuing the right levels of care and the right nature of care in tandem with the translocation. And then my last point, you don't need to answer now because it probably needs a bit of research, but it's to do with mental health and the challenges that A&E faces. And I suppose it's really a question of the definition for the purposes of Section 136, the Mental Health Act, of a public place, because my understanding is that the definition of a public place very often means that people with mental health episodes, suffering mental health episodes, might not be easily accommodated, but might be sort of shipped off to a police station to safeguard the public. And that has numbers of implications, which I think might be unfortunate for the patient. And so it would be useful if my understanding of that definition is correct, just to think about what we do about that definition in future, but you don't need to answer that point now.
Okay, well, if I answer the first question and make a comment on the third, but perhaps I'll ask Jane to answer the second. In terms of the timeline, we start the planning at the beginning of the year. And this year we were particularly keen to make sure that the local health economies plans were assured before we allocated the money, and that they were absolutely targeted at the right thing. So we undertook an assurance process across the summer, and for most health economies, I mean, for some of them where we had a great deal of level of confidence, largely based on their delivery, we didn't look particularly close at plans. We knew there was a sort of earned autonomy. But for ones where we had concern, there was a process done by the regional and the local teams, and again done in collaboration with our tripartite partners, in order to get us to the point whereby the vast majority of plans were assured. And we reached that point in September. Just because the plans aren't assured doesn't mean that we didn't go on to release the money, obviously. So the majority were assured, and people were, right, off you go and spend the whole money. Where they were not assured, it was simply a question, well, you can start with this amount, but we need some further detail on what you're going to do. So everywhere should have had, and I think the vast majority of places absolutely did have, by the beginning of October, absolute clarity on what this money was going to be spent on. And that means that the providers were confident, whether that provider was a hospital taking on extra beds or extra staff, or it was a community trust with community beds, or some initiative in the community, confident that that money was available to them and they could put their plans in place. We then continue to have interaction with all the health communities, including a scenario whereby the ones where we're most worried are escalated, and they come in to talk to the three chief execs, Simon and David Flory and David Bennett, about their plans and what they're doing. And what is apparent is that a lot of this capacity has been coming on stream October through December, and some of it into January, because of course some of the issues are about recruitment, and that takes a little bit of time. So that's the timeline for the capacity coming on stream. What we do on a monthly basis for every system resilience group, we have a comprehensive they have to submit a comprehensive plan of everything that their money is being spent on, hence we can produce that pie chart, and then when it has been spent. So we've got another return coming in this week, so that we can track that people, if they've said that they're putting this capacity in place, the capacity is in place and it's online. So that's the timeline. On the incident, which I'm assuming you're alluding to, it is completely unacceptable that the NHS is not in a position to find a bed, a secure place for an individual who needs our care, and as obviously has happened recently. And I think that we have seen pressure on those beds. We have put a significant amount of additional investment in. We are absolutely treating that as a serious incident, which is being fully investigated, so that we can have the lessons learned from that to make sure that it doesn't happen again. But Jane, do you want to add on that?
Just add on the Section 136 issue that Margaret was alluding to. So actually, as you know, crisis care concordats are being developed and signed by partners across the country. We want to see them universal across England. where they happen and where they are backed by action on the part of all of the agencies that come together, we see dramatic improvements in the reduced use of police cells at times of mental health emergency. Actually, I think Section 136 usage in police cells is down by about a quarter, and we're probably on track to bring that down by about a half. That, together with some of the extra money that's gone into the system this year for liaison psychiatry in A&E departments, and the fact that, let me just give you sort of one flavour of it. I was recently down in Bristol talking to the folks doing the Bristol Mental Health Services, met with the police down there. They had one crisis diversion bed, they got 4. That's had a dramatic impact in Bristol. We know this is doable. It's almost getting to the point where we should regard this kind of incident as a never event, a sort of mental health never event. And so I think making a reality the crisis care concordat with the extra investment that we want now to see going into mental health services on the back of the allocations that we've just approved, that should be one of the things we look to local mental health providers and commissioners to get right in 15-16.
Ed?
Less.
Should we do the transforming care one?
Well, I just
Or
wanted to...
carry on?
Ed had indicated that he wished to come on this.
No, what I guess the point is if you're running a large public business, organisation, service, I think one of the things you might want to do at some point is for the board to see the analysis of root causes. So what are the exogenous variables that have given rise to this surge? What are the endogenous ones? How do you drill down and work out? Because, I mean, you know, you're sitting here now, we haven't had an enormously bad set of exogenous weather impacts yet, or any particular viruses that have particularly. So working through, Malcolm, probably at some point, do we take a paper on looking at the data and understanding what the data is really telling us? I'm sure the exec and Barbara does it, and maybe others in the system do it, but I would like to understand it, because I think we have an obligation to know what is impacting on this surge, and then really start to look at what you do about it.
And it will come up in Bruce's report shortly on the review of urgent and emergency care.
Can I mean, I'm sure we should bring data, but obviously we spend considerable time trying to identify why we have seen the rise. You know, it's an inexorable rise in patients, both in the attendances at A&E, but certainly when you talk to the hospital chief executives, the biggest issue for them is the admissions. The patients who are admitted, and what they're saying, you know, what we've seen is we're seeing increasing numbers of patients, and we're seeing an increased acuity. So the patients are ill, and now some of this is demographics, some of this is, you know, we are living longer, and people have there are more people with many comorbidities, and then when they get one illness on top of that, they become iller, and they're therefore in a hospital bed for longer. Their stays longer.
And that's fair, Barbara, of course, and that would be regarded as an exogenous variable. On the other hand, an exogenous variable like that would be known about, unlike a volcanic cloud that just sort of happens in Iceland. You know, this is known long-term trend, which would then tell you that the response to that is different, or should be different than perhaps the
So I think it depends how broad you define the system as to what counts as endogenous or exogenous, obviously. But I think what we're seeing is a fraying of the capacity of primary, social, community, third sector organisations to sustain people independently, and so this is the big thrust of what we're trying to do in a way with a forward view in these communities, and it can be done because I met with folks from Southampton earlier in the week, and there they've seen almost flat rates of increase as a result of having been very thoughtful about the investments they've been making in other parts of the broader health and social care system as defined. So I think there are some sort of pieces of the jigsaw here, and you know, some of it's what Bruce is doing the urgent care review, some of it's the broader whole economy, whole system working that we want to see, and that's part of our 22 billion challenge. If we can moderate the rate of increase in demand, we don't actually need to cut demand, we just need to moderate the rate of increase. That counts as offsetting some of the pressures that otherwise we'd be bearing.
I think there's also a third component to this, which is the endogeneity, if I may, which is but it's the management. I mean, I went recently to a foundation trust in a really quite challenged health economy outside London, where the rate of increase of attendance in A&E has been going up steeply, between 300 and 400 people a day, where the 4-hour rule is regarded not as a target but as an indicator of safety, where performance is above 97%, and where no operation is cancelled as a consequence of overflow from A&E, where the Trust have employed 7 consultants in emergency medicine, are recruiting another 3, and where there is a commissioned GP practice right adjacent to the A&E entrance, where patients are immediately streamed. So the endogenous capacity feature is that amongst all the data that we get here, which is very high-level aggregated data, it strikes me there's quite a lot of variation in the way in which different trusts are managing this. Final component of this is that this trust has a turnover of about 250 million and a 5% positive EBITDA, and it's all done within tariff.
I'm sure this is for a longer debate, because quite plainly there are the issues of the population. You are absolutely right. In terms of making sure that patients are seen swiftly and quickly, really well managed economies and trusts, it makes a big difference. There are some simple things that we know, the checklist of, if you make sure that your patients who are ready for discharge and ready to go home are seen by the consultants early in the morning, and go home early in the morning, then you've got your bed is available. In some of the more challenged places, actually, the patients aren't being seen and sorted for discharge until 5-6 o'clock in the afternoon, and that you've almost lost the bed on that basis. In some areas, it's about cuts to social care, because then the Better Care Fund will be part of the future solution. And I think this maps onto the conversation we've just had about distressed economies, because there are some economies where things are so difficult and challenging for them at the moment that their ability to then go out and recruit those extra consultants that they need are very difficult. Some places it's about the difficulty in recruiting. There are some areas of the country where it's much more easy to recruit doctors and nurses than some of the more rural areas. So I think there's a picture builds up for every single health economy as to what the problems are, and certainly be happy to try and bring something back to articulate that.
Victor?
Yeah, I suppose that the question that springs to mind is there are some things which lend themselves to repeated good management practice, and it's just a question as to the extent to which we can repeat what works in the example that you've given, Malcolm, elsewhere. It's just a straightforward, well, if they're doing it, what's the excuse for you not doing it? Which is a question we just don't know anything about. The second point actually relates to Ed's intervention, which I think is relevant, actually. I'd like to understand a bit more about the drivers, because there's some, there is an inexorable rise, as Simon has pointed out, but I'd like to understand a bit more about the demographic issues. So, for instance, in London, there are 300 languages spoken. There is a flow in and out of the population as a result of migration. How does that drive this issue, and to what extent do our interventions actually match that demographic? And in other parts of the country where there's a similar demographic, I think we do have a duty to understand that, because I think it drives the question of measures and leadership, which we've addressed earlier. So the question I was going to ask, which is I think a lot of work's been done, clearly, but I just wondered, do we have any sense of differential planning or communications in different areas that relate to the demographics by age, race, whatever, that might have an impact on people's use of A&E? I mean, do we have that kind of information?
I think two points to answer. The first point, you first point you made was about good practice, and there is a team called ESIS, which is the Emergency Care Intensive Support Team, and that draws largely from the managers and consultants in the hospitals who do well and do exactly what Malcolm was talking about. We're using them a very great deal at the moment to go around there, and they've got a checklist, and they're very clear about which. There are 7 or 8 big actions that make such a huge difference, and you know, they can prioritise and they can tell you what percentage. So that's absolutely going on. In terms of people tailoring their local services, there is no doubt that that's happening. You know, I see the services in Bradford where it's clear that you know, for so many of the patients, English is not the first spoken language, and the wealth of ways in which the CCGs there make sure they can communicate with people who can't read English. And of course, often the issue is that often if you can't read English, sometimes you can't read at all. So and therefore for these communities, there's a lot of work being done in places like Bradford and Leicester to make sure that actually things are done verbally, and there are audio tapes and things. So I think our local communities do work really hard, both to make sure they can communicate and to make sure that services are tailored. So again, you know, with ethnic minority patients, there are certain features of a service that you need to tailor well to make sure that patients will use that service. Do we in NHS England have a systematic approach for collecting that to report? Then I don't think we do.
You also, Victor, asked about age as well as diverse communities, and I think we have a hypothesis that we've not yet worked through or vetted that is coming at us from what a lot of the ambulance trusts are saying, that for a lot of people in their 20s and 30s, actually the idea of kind of, you know, bits of paper, appointments, waiting rooms, I mean, that's like sort of an alien concept from a previous century. So actually kind of, you know, getting on the 999 phone if you can't think of anything else, or and ending up in that system as a sort of point of interaction with the health service. I think we've got to, as part of the urgent care review, radically reinvent the offer we make for people who need kind of instant access, particularly from some of these other demographics, and the work on digital, the work on new ways of it. All of this is kind of our agenda, because we just can't rely on our current gateways, our sort of piping to work for the diversity of people who need to interact with us.
Yeah.
Okay, well, thank you. I think it's probably time to draw discussion on these 2 items to a close, but conclude that the board takes assurance from the papers that we've received and from the discussion that we've had, that secondly, there is an interest around the board in taking a deep dive and looking at some of the exogenous, if I may use the Ed Smith term yet again, some of the endogenous and exogenous factors that relate to our management, particularly of urgent and emergency care. We're going to come back to that in a moment, but what I'm going to propose to the board, with your generous consent, is that we might take a break of 10 minutes. There's some heavy lifting to do in the remaining part of the agenda. And may I ask you then to reassemble here at about 1:45? Thank you very much.